Hello, and welcome to Clerkship Ready-Pediatrics, a podcast aimed at helping you excel during your clinical clerkship in pediatrics. I'm Dr. Rachel Moon. I'm a general pediatrician and professor of pediatrics at the University of Virginia. Also, welcome to pediatrics. As a pediatrician, I know I'm biased, but this is definitely the most fun clinical rotation. However, it is also one of the most challenging rotations. Why? Because every single patient will be different. You will see patients from birth until their early 20s. That is a huge range in terms of size and development. The physical, developmental, emotional, and mental issues at each age are different, so there is a lot to learn. As one example, your differential diagnosis for a 3-week-old patient who presents with bloody diarrhea will be very different from your differential diagnosis for a 3-year-old patient or a 13-year-old patient with bloody diarrhea. Even the infectious organisms are different at different ages. So first, let's talk about some essential resources. Many of the resources I'm going to talk about are also available through apps. All of these are also listed in the show notes. First, they're podcasts. Of course, you're going to want to listen to Clerkship Ready-Pediatrics. Charting Pediatrics is a popular podcast from Colorado Children's Hospital. It is a weekly podcast in which they discuss a particular topic in each episode, and there's a lot of bread and butter pediatrics discussed. The American Academy of Pediatrics has a podcast called Pediatrics on Call, where they discuss the most recent research and the newest policy updates from the AAP. For books, the AAP has the Red Book, and that's actually what it's called. This is the definitive source for pediatric infectious diseases. The Harriet Lane Handbook is a commonly used reference that comes out of the Johns Hopkins Pediatrics program. It has drug doses, commonly used charts, and algorithms that you'll find helpful. A great website for you to use is PD Tools. This is helpful when you're on newborn rotation or seeing a newborn for whom you're concerned about hyperbilirubinemia, and you have to decide whether or not the child should get phototherapy or not. Up to Date is always a great resource. For vaccine guidelines, particularly when guidelines change frequently, as was seen when the COVID vaccines were approved, the CDC website is a great source of information. If you specifically want to work on illness scripts, there's an app called PedScripts that is very, very helpful. Here are some general tips and tricks that are relevant to any rotation. First, be proactive. Talk to students who just finished the rotation about what to expect, the day-to-day logistics, and ways that you can be helpful to the team. Expectations. Ask for them to be set at the beginning and clarify them as needed. Become familiar with the electronic medical record system. Know how to access former visits, both at your institution and outside institution, and information about medical problems, medications, allergies, and vaccinations. Be self-sufficient, but ask for help when it's appropriate. There is a balance between being proactive and knowing what your limitations are. Before leaving for the day, ask when you should come into round, who to pre-round on, and where to meet. If you can, pair up with an intern to pre-round. Once or twice a week, it's good to ask for feedback when everyone has a down moment, but be aware of the right time or situation to ask for feedback. Now for some tips and tricks that are pediatric specific. First of all, as I mentioned, pediatrics is different from any other rotation. At every age, children act differently, and so you need to adjust appropriately. Remember that children are not little adults, so depending on their age and their developmental status, they may or may not act the way that you're anticipating. A 15-month-old will likely scream as soon as you come close to them. A 3-year-old may try to kick you or pull your hair, so be prepared. A teenager may just play on their phone the entire visit unless you engage them. So you have to adjust how you do what you usually do. If you can, get as much of the history from the child, but you'll likely need to supplement that with history from the parent or guardian. Then, when you do your physical exam, depending on age, you may not be able to do the exam head to toe. For school-age children, you can usually start with the head and make your way down, but you can't do that with younger children. First of all, don't make the child move if they're comfortable and feel safe. You can do a lot of the exam while the child is sitting on the parent's lap. Take advantage of when the child is quiet to listen to the heart and lungs. I usually start with the heart and lungs and then move on to the abdominal exam. However, if I need a good eye exam, I may start there and then move to the heart and lungs. After I do the heart, lungs, and abdomen, I usually go to the head and neck exam. I generally save the ear exam for the end. If the child starts crying, then you have the opportunity to look in the mouth and the throat. But even if you do the exam in reverse order, you always try to present your physical exam in head-to-toe order. Remember that vital signs change with age. For instance, in a newborn, a normal heart rate is 120 to 160 per minute, and respirations are about 40 per minute. That's very different from what we expect to see at 4 years old, when the normal heart rate is 80 to 20 a minute, and respirations are about 25 per minute. So look up or ask about what is a normal vital sign in the age that you're seeing. We also consider the growth chart to be the fifth vital sign, so always look at growth, height, and or head circumference and report both and present both percentiles and trends. If the infant has been born prematurely, then you'll want to adjust your expectations for growth and development to account for the prematurity. In the first 2 years, we correct for gestational age. So for instance, if a baby was born at 30 weeks gestation, that's 10 weeks early. So at 6 months of age, you would expect this baby to have the growth and development of a 3.5-month-old. Also, because we take care of a wide range of ages and sizes, we have to be sure that the amount of fluids, medication, or anything is right for the child's size. Almost everything is dosed per kilogram. However, for older and larger children, you have to double check what the adult dose is because that's usually the maximum dose, and you don't want to exceed that, even if the child's weight would call for more than that. The last thing I want to mention is family-centered rounds, which is a unique and important part of pediatrics. The goal on rounds is not to repeat the entire medical record, but to get both the team and the family up to date on the patient's diagnosis and overall course, and to formulate a plan for the day together with the family. So just like it sounds, in family-centered rounds, the focus of the rounds is the patient and family. It's not just the passing of information to the medical team. Family-centered rounds allows us to both provide information to the family, increase their health literacy and understanding of the child's medical issues, and involve the family in decision-making. Everyone, including and especially the family, should be encouraged to ask questions, clarify information, and review the daily plan. Since this may be the first time you've been part of family-centered rounds, and because different institutions may do it a little bit differently, here are a few tips. Usually, there's a brief summary that occurs outside of the patient's room. This is where any sensitive information is shared and where you review the plan so that the whole team is on the same page before they go into the patient room. Then, one team member usually lets the family know that you're rounding and asks them if the family would like to participate. While family-centered rounds usually occurs at the bedside, depending on what's happening at the time, family members may join the team outside of the patient room for rounds. Other family members may decline to participate depending on what else is happening at that time. Remember that because you're talking to the family, your language needs to be conversational and not include medical jargon. You want to be concise and clear so that everyone in the room can follow along. That's it for tips and tricks. Thanks for listening to Clerkship Ready-Pediatrics. I hope that you found today's episode helpful. Don't forget to subscribe below and rate the podcast.